Hi, friends. This is Dr. Ravi Kamepalli. I'm an infectious disease, wound care, and obesity medicine doctor. I'm now in Delhi, uh, going to be attending a conference for Indian Podiatry Association, which is an organization that was started in 2009 to spread the knowledge of diabetic foot care and, in fact, foot care and wound care in India, and it has grown up to become a strong organization with a presence in 18 of the 28 states. And essentially, it's a national organization trying to still work hard to change the thought process and improve the health of the patients from a wound healing and diabetic foot and metabolic health standpoint. And I happen to be the vice president of the organization, and uh, basically, I just am trying to envision a national mission for amputation-free India as directed by the president of IPA, and also to create a preventable amputation-free India by 2047. And towards the theme, we are presenting this approach, and we're trying to create diabetic foot occurrence and remission prevention through team technology and tenacity. And I'm so happy to be presenting that. And as a part of that, I'm trying to record it ahead so that if there is any time crunch, I could post it down the road, and hopefully people can review it. So, so the next one is I just want to relay my conflicts of interest. I have been trying to build a comprehensive solution for telemedicine for infectious disease, obesity, and diabetes reversal, and obesity reversal, and wound healing for quite some time. It has been my dream project, and the motivation for that is be the change that I want to that you want to wish to see in the world by Mahatma Gandhi. And I practice now actively in Atlanta, Georgia, and my website nobadbugs.com, my social media at Wound Physician, and removing barriers to healing. And at the end, I will discuss about a platform-based approach that I'll be trying to promote, and that's part of my disclosure so that you're aware. So what are we going to do is quickly, objectives wise, we will define the problem clearly, set a vision for 2047, and introduce a strategy framework for Indian Podiatry Association strategy, and clearly come up with some global practices that can be used here, and also discuss about ecosystem platform-based modeling, and also collective action plan will be determined. And we have to understand that India stands at the epicenter of diabetic tsunami, which is a huge, not even an epidemic now, a pandemic in the whole country, with almost 90 million Indians having this problem, with 1 in 7 globally being an Indian with diabetes, and mostly even 43% or more than nearly 39 million are unaware that they have it. And by 2050, it is supposed to be going up to $157.7 million, with the staggering statistics happening, making them their lives and limbs in risk. And together, my hope is to change this story a little bit. And this data was from IDF Atlas from 2024. So basically, there was not much data available, or it is haphazard data, but there was one study that came out in BMJ from the group in India. It was sponsored by RSSDI, which was impressive that we were able to get a snapshot of what's going on in India. And basically, this was a snap survey that was done from July 10th to August 10, 2022, with 10,000 doctors being trained and 33,259 patients screened. And the 3-minute foot examination was used, and previous data was not available clearly, and national level of prevalence was not known. And this study is significant that they found that there is a 25% high risk for the feet, and also a robust national snapshot was given. And proof of concept is to be able to integrate that this approach of a 3-minute foot exam in primary healthcare system. And they found that in these high-risk feet, 1 in 4 diabetics in India have high-risk feet, 20% have diabetes ulcer, and 15.3% had amputation, 24.5% had deformities, and 26.4 has reduced pulses. And the message that they were trying to promote is early detection saves lives and limbs, and also foot screening should be standard of care with education on footwear, offloading, and fewer amputations would be the target. So, I mean, this whole process, as you can see, is a key finding wherein the rural areas had detected 20 to 30% neuropathy, and obviously we need to create this local data from this local data and national data that was across the country, and take this up to the next level by creating the next steps. The call to action here was to screen every patient with diabetes in India and train the doctors and nurses with 3-minute foot examination, and invest in primary care and foot health. Now, this is a good idea. This is a good study, but the problem well stated is a problem half solved. Charles Kettering. This was an inspiration for me to think. Now, the question is, we know the aspect of the care, but how can we take this from campaign to continuum? These campaigns can be timely limited surveys, but we need to track and make things improve. And this can only be done by creating an approach wherein we have a platform, we have a approach with integrated solutions that are limited right now to be clearly creating prevention of amputation and removing barriers to healing. And we have to move from time-limited survey to continuous routine foot care, integrate screening at primary care level, and also create patient-centric and provider-driven platforms for ongoing monitoring and track outcome and ulcer healing and recurrence prevention and amputation prevention. And screening is the endpoint and healing is the machine. So we need to screen them early, create a platform-based solution and high-touch wound healing approach with metabolic optimization, and also integrate this at a health solution with a healthcare system that is needed to be involved very closely. So the policy implications are that we need to move it from for current status to the better approach of including diabetic limb preservation into non-communicable disease program integration, add foot care screening, and also build on the existing infrastructure that is there. And limitations are screening for mainly currently is episodic and without strong referral pattern and long-term follow-up and the team-based approach. And the better approach would be creating a limb preservation strategy, referral patterns, and also create a process of training primary care nurses, ASHA workers at a national scale, and making amputation-free survival and non-communicable NCD program of quality metric. The significance of diabetic foot is huge. It saves lives and limbs and a significant hospitalization cost. And all this can be done outpatient easily. And we need to be able to change the thought process, social factors, barefoot walking, and also timely screening is needed as there is a significant loss of protective sensation when people walk on bare feet. So in India, this problem is huge as diabetic foot ulcer doesn't take feet, it takes futures. And each amputation removal causes livelihood problems, independent loss, and dignity problems. And amputation rates are in India are among the highest, and that needs to be prevented. So we need to create this model with IPA advocating for prevention of amputation as many preventable amputations that could be taken to 2047, and also we need to create its embedded care where there is embedding care that is integrated with diabetes and screening patients with dialysis and also cardiology problems, people who have geriatric conditions, and also education that can be done with local languages, and also risk stratify and monitor annually, quarterly, and monthly, and provide care equitably across all regions and using different tools, techniques, and processes. And a good system will uplift every patient and every professional, and outcome level impact is going to be huge with saved limbs, reduced DFU ulcers and amputations, and preserved livelihood and families protected, and economic collapse prevented, maintaining independence and less caregiver burden and more dignity, and lowering the cost and fewer hospitalization and surgeries. So what could be the strategy is starting to look at this problem from the eyes of the patient framework. And we need to look at patients as not cases, but humans, and prevent the delay, prevent the costly travel with telemedicine technology and integrated care and hub and spoke model procedures, and leading to all these are leading to quick limb loss and amputations, and this disability can be prevented. And the dimensions of healing are three. Number one, clinical metrics. We need to look at metabolic approaches like looking at blood sugars and hemoglobin A1C sooner, ulcer healing durations, prevention of recurrence, amputation-free survival, and also economic burdens. I'll look at the dimension of economic burden that prevents the loss of work and indirect costs and depth and the travel and human dignity loss with mental stigma and mobility and pain issues. How can we do this? It's simple. Create the screening and prevention process in the foot screen approach, where 60-second foot screen, look, feel, test, and ask, and take off the shoes and look at it. Risk stratification and education about daily checks, hygiene, footwear, and call for early help, and therapeutic footwear and temperature monitoring, and monitoring for high risk approach, where foot screening has to be a first step to this process. The next one would be ulcer management, where we are able to offload and use a standard of care with TCC casting, and also different footwear, and infection detection, classifying them as mild, moderate, severe, and early debridement of devitalized tissue, antibiotic use if needed, and also check for significant vascular problems with ankle brachial index and toe brachial index, and fast tracking vascular referral and revascularization, and coordinating team approach, and obviously active wound care with moisture control, moisture optimal control, and promoting moist wound care delivery, and also systemic optimization. Now, the next step is remote monitoring, remote patient monitoring, or remote physiological monitoring, where we can prevent the remission and monitoring, where the follow-up can be done at 1, 3, 6, and 12 months, and semi-annually if needed, and refitting the people with repeat footwear changes, and reinforcing education, and reviewing the remote patient monitoring data with pictures of the foot, like using a foot selfie, and also temperature sensor monitoring, and step counts. And we need to create a fast lane for patients to be seen sooner. And we need to come up with this strategy where systemic strategy, the system lifts the patients and the professionals to be able to do their job the best. And we need to be integrating this into a national NCD program at primary care level, and also therapeutic footwear subsidies have to be given. Equity guardrails have to be created so that cost should not be an issue. And weekly limb preservation hurdles need to be done at hospitals, including district hospitals, and care delivery dashboard has to be created where there is coverage, there is timeliness to get to the people that are suffering. Prevention of recurrent and amputation rates can be reduced. The public message is simple: check feet daily, call for help. That's the key for preventing amputation and removing barriers to healing. And the goal is getting to the metabolic tsunami that is the real problem that is facing this country, wherein 100 million people are living with diabetes and diabetic foot complications. And most devastating outcome in this whole process is amputations. And the tragedy is 80% of these amputations are preventable. And diabetic foot amputations can be taken care of by this core aspect of coming up with a team, technology, and tenacity. And that team is what we have been training at Indian Podiatry Association from 2009, trying to get the doctors collaborating with and trying to improve their knowledge, getting certification and training, and trying to integrate this whole process into multidisciplinary model with a patient-centric and professional-driven manner, using technology, using digital foot wounds and metabolic monitoring, including food logging, glucose logging, and also doing this in an affordable level and creating a national registry. And AI-driven triage can be done with this. And tenacity, the power of India is the numbers. But then the numbers could be going to waste because we don't have a clear-cut policy integration, national championship that is done. And we need community empowerment, patient centricity, and a professional-driven approach. We can create a metabolic simple approach where a nutrition that is patient-centric nutrition using continuous glucose monitoring, or as SMBG where the finger sticks can be used, and other advanced approaches including ketone monitoring and adequate food delivery, adequate nutritional delivery should be the foundation of remission. And our roadmap for Preventable Amputation-Free India involves early pilots, national expansion, global leadership, and ensuring every Indian with diabetes has a chance to live an ulcer-free, infection-free, and amputation-free living. And it's time to stop accepting what's broken. And to do that, we have come up with a strategic process of pillars of this whole process called team, technology, and tenacity, with multidisciplinary approach, technology with AI, digital platform, food logging, glucose foot logging, foot wound logging, offloading, and creating a national registry and campaign through a policy integration and community empowerment, and metabolic integration into this process where the energy toxicity happens to be the driver that leads to all the neurological, vascular, cardiac, all the problems that are causing this problem, and faster healing and tracking this and preventing of remission. And this integrated foot care approach that integrates metabolic approach using a whole person, not a hole in a person approach, is what we are advocating for. And this integration of metabolic care process includes approaches that are energy adequacy with the, in a toxicity paradigm where there is energy adequacy versus energy toxicity, a low carb nutrition, but we're not promoting any certain nutrition. If a certain nutrition is that patient is following, we just track it and teach the patients. And there are alternatives with low carb approach, with vegetarian approaches that could be easily implemented. But also we need to create a solution where they improve the muscle mass, and other supplementary process can be done. Food is a power, and that power can be harnessed. Any dietary lifestyle can be used to improve the metabolic health, and outcomes of that need to be tracked, and prevention of problems reoccurrence has to be done. So this whole approach is a process that has to be followed with a pilot that can be done in 3 to 5 states with 10,000 workers trained and registry created. And phase 2, where 500 centers with AI integration and annual screening mandated. And phase 3, 2020 to 2047, and nationwide coverage done, and India will become a global leader in amputation prevention. And this process is simple. My call to action for this whole approach would be getting governmental integration of diabetic foot into non-communicable disease programs, and societies like IPA and RSSDI and other diabetic foot organizations, diabetic societies, endocrinology societies, obesity societies, and different societies that are in silos of excellence that is being done with excellent care in territories, have to come together and integrate and create processes wherein we create a research process where this hub and spoke model that we have here from IPA that we're developing, and technology partners have to be brought together and adopt a multidisciplinary patient-centric approach, and communities and patients have to be integrated into into this prevention process and start building what works, and don't accept what's broken. It's time that stops. And the team includes together everybody achieves more, TEAM, that is multidisciplinary certification process and hub and spoke model, and task shifting to the community level, and a solution that is developed and delivered at scale, wherein we are using a technology and a national registry, and also tenacity, wherein we don't give up because every life counts, every human being counts. And research, training, and outcomes have to be integrated into this strategic mission, and the mission has to improve the metrics, the framework of which would include ulcer-free days, recurrence rates, hospital-free days, and standardized care include perfusion to the foot, debridement, infection control, offloading, and using smart soles and different socks, and targeting high-risk population. So the tiered implementation of this includes standardizing and creating a pilot 1 year, medium, the second 2 to 3 years would evaluate and scale it, and third would be AI-driven prediction and rural health expansion. And this preventable strategy involves the whole process, wherein we have the vision of training process, the phases, the challenge of treating 100,000 Indians and preventing 80% of this process amputations through early detection. We have strategy pillars of team, technology, and tenacity. We need to involve the government, involve the communities, particularly involve the patients who feel taking the brunt of the problems, and also we need to bring together metabolic health improvement approaches where the patients get empowered. In this first year, we need to implement, create this knowledge gap improvement using telemonitoring micro centers at the primary health centers, create hemoglobin A1C, and also SMBG, wherein we are able to check the blood sugars. We need to create a multiple areas of not just WhatsApp governance is being used in different states at this point that can be harnessed to increase the engagement, and fragmented care needs to come together with e-referrals, e-Sanjeevani, and monitoring with SMBG and CGM, and getting the data done. And India, did you know that India has highest number of type 1 diabetics in the world? And we need to understand that we need to create this silent foot disease avoided, and we need to create the footwear vouchers and offloading aspects, and we need to create the process of retinopathy detection, which is eye being the window to the world. And we need to move away from this basic problem of metabolic ill health that focuses only on glucose, whereas we have to get it to the metabolic syndrome process, where the problem is insulin resistance and metabolic syndrome, which involves five things, which blood pressure, blood sugar, lipids, sleep, activity are side, but waist circumference and lipid parameters of triglycerides and HDL have to come together to identify the metabolic syndrome. And we need to create a pathway. This is a little complex here, but we need to create this pathway wherein we need to create this triage process, and process where we are able to look at key aspects of toe pressure index, severe ischemia, offloading, X-ray, and simple processes that identify the patient, triage them, and get them to the primary care centers, district centers, and tertiary centers, and vascular centers. And limb salvage models have to be done, and limb salvage boards have to be created. So the IPA strategy is integrate screening into a national non-communicable disease programs, therapeutic footwear subsidies, weekly limb preservation hurdles, and timely illness coverage for the patients, recurrence prevention, and amputation rate improvement. We need to public message again is check feet daily, and call for help. And our call to action here is building strategies with patient-first lens, train professionals with empathy, and measures success as years of dignity and mobility preserved, and every patient, every time. That has to be the motto and vision. By 2047, every person with diabetes in India will have access to preventive foot care, risk-based monitoring, and systems that remove barriers to healing. And join us in building a preventable amputation-free India. And why this matters, we all went through. Early detection saves limbs and lives. And join the group through this approach. And let's pledge for I prevent amputation and removing barriers to healing. And together we can make amputation-free India by 2047 a reality. And reality and dreaming is great, but you have to understand the technology platform is needed to achieve it. And I've been working on this since 1995, trying to work on this to build. It took me until 2009 coming across the amazing president of IPA, Amarpal Singh Suri, and we ended up creating Indian Podiatry Association and trained a few doctors. But the next step is to take it to the next level. How do we do it? With technology. So how do we bring together this whole process is simply creating something called as heart-foot line, where we build a scalable app-based diabetes limb preservation program, which involves step one, building a heart-foot line. Step two, developing wound clinics with outpatient model to manage and prevent tissue loss. Step three, remission clinics and outpatient care to extend to ulcer-free and hospital-free and activity-rich days. And step four, screening clinics that target prevention. Now, how do we get this? Is Ashoka Chakra is an implemental inspiration for this that made me think about Indian Podiatry Association creating this knowledge network with a technology-based solution that integrates the concepts of a professional practicing this using clinical research approach and management, and obviously spreading and making this a detailed approach. But technology, we had to come up with a remote patient monitoring solution that has wound care, metabolic health direction with nutrition, electronic record communication, and AI-based automation and risk stratification. So this approach is a whole person approach that helps this whole heal in the diabetic foot, but also treat the patient as a wholesome patient that needs help and guidance and prevention of even occurrence, forget about reoccurrence. So many companies do this, but they are all fragmented, excellently doing in their silos. What I've been working on is in the wound assessment and documentation process, which can come on. Wound healing driven by intelligent AI, wound monitoring and patient education, and metabolic wellness and guidance, depending upon how the patient believes what is best for him, and educating them on improving themselves. This automatic wound measurement process, where we are able to simply automate and measure and bring this into a technology-based platform where the database is there, and basically patient is able to acknowledge and understand how bad or good in the rural setup this patient is, and how quickly the patient has to come up to the help. So the wound care risk stratification using different risk scores and wound healing timeline can be documented, and next dressing change has to be addressed. It's simply tracking the wound pictures, dressing using barcode, and recommended plans being followed or not followed can be tracked. And AI-driven patient insights and chatbots can be used to guide the patient on improving themselves. And patient education and content to read can be easily delivered, targeting in a personalized manner. And this, if we're doing this at this point in Atlanta, in my clinic, where we are able to generate this guidance, reverse diabetes, depending upon the patient's nutrition and wound healing, and customizing their solutions and reversing diabetes. And we were quoted in a few international newspapers as salvaging the limbs for that. And I will share that in my next video, but I forgot to put that here. But patient engagement is key for this whole process, that is directly correlating with wound healing and better overall outcomes. And healthcare providers have the power to expedite the healing process in engaged patients. And engagement is simple. We connect, we upload the pictures of, these could be the pictures of the wound and pictures of the food, and engage with the providers through a dashboard approach, and we can track and track the progress greatly. So the approach is patient centricity, where we treat the patient with the power of their own data using AI, using a systemic approach where we are doing metabolic wound healing, wound care management, engaging with the patient in a convenient app-based experience. And our platform offers a unique patient-centric approach for it, and the continuous data enrichment and automation and patient insights. And this is what I've been developing just for Indian Podiatry Association since its creation. And I've been working hard to make this happen. And we did try it in 2019, but since I needed a team, I had to come up and collaborate with this organization and join, so that the wound doctors can have a better outcome in India, where there is more problems, and the whole process could be documented easily using voice-based wound documentation and high-touch wound care patient management, where patients are engaged and easily take pictures, and also integrate durable medical equipment like wound care supplies into the product delivery model. And this whole process is so easy to do and implemented, but as medical professionals, we need to understand that we have to be at the forefront of engagement, create the team. You don't have to do everything. We have to be able to bring that team approach and provide that solution to the patients. And this is a simple approach. And again, we need to be the change that we wish to see, not complain. We need to move this whole process from a complex system to an empowering platform-based approach. A bad system will beat any good person. There are many good doctors in India, and that a bad system, we can complain, but a system is never going to change if we don't take the ownership of that change. The fragmented care has to change. The reactive process has to improve. The lack of data integration. Without data, we are another person with an opinion, and with just an opinion, nobody is going to care for you. So we need to improve it to a good system that will uplift every human who wants to help themselves, using a platform-based approach, using national, regional, and even practice-centric approach, where the clinical practice can take it and deliver it at scale. The travel time can be saved. The costs of travel time can be integrated into the cost of the delivery of the solution, and provide solutions that the patient can then be able to be independently taken care of, and with a high-touch solution. And we need a system design that involves people, process, and technology, and the outcomes that has to be at precision, at scale, and better outcomes, greater efficiency, equity of care, and sustainable design that brings up a good system that empowers the patient. Thank you very much. And thank you very much for taking time to listen through it. And hopefully we'll get that happening. Thank you. Thank you very much.